Okay, we're recording. Let's go ahead and start on this.
Should we wait for the clock?
You'll come in.
I think we'll be good, no?
Yeah, we're okay. He's not first, anyway. You're first, so.
Okay.
So I'll introduce everyone. Okay, so hi, everyone. Welcome to the fourth day in the College of Health Sciences Week. So throughout the week, the college has been hosting a number of events to showcase activities in the health sciences, including interdisciplinary activities with our other colleges, the College of Arts and Sciences, the College of Engineering, and our College of Business. And our panel discussion today on the future of technology in healthcare is co-hosted by our NYSTEC Business Center of Excellence. I'm Jim Stahar. I'm on the faculty in the College of Business, and I'm also serving as the director of our NYSTEC Center. Before we begin, I wanted to thank the Dean of the College of Health Sciences, Mark Kittleson, for helping organize our panel today and all the events this week. I also wanted to thank the Dean of our College of Business, Rafael Romero, as well as the President and Provost of SUNY Poly, and all the faculty and staff at SUNY Poly for all their support for the center and our colleges and all of our activities. I also wanted to acknowledge all of our faculty, our students, and our staff for attending our panel today in person or virtually, and also wanted to acknowledge all of the guests from SUNY Poly. So today, Nick DePaula, Jacques Poudenou, Joe Zhu, and Amir Manzoor have nicely agreed to speak with us about different areas of technology in healthcare. Nick will lead us off with a presentation on AI in healthcare. Then Jacques will present on issues of technology and clinical practice. Joe will discuss the use of medical robots. And finally, Amir will talk about bioinformatics. And after each presentation, we'll have about 5 minutes for discussion about some of the ethical issues that are relevant to each topic. And then after all of our presentations, there should be more time for more questions from everyone. Now, before we begin, I wanted to introduce briefly each of our panelists. Nick DePaula is an assistant professor of health informatics in the College of Health Sciences here at SUNY Poly. His work addresses issues at the intersection of information technology, government communication, and public health. His work has appeared in several prominent journals, and he has presented at several national and international conferences. Jacques Poudenou is a cardiovascular surgeon and an NIH-funded scientist at Beth Israel Deaconess Medical Center in Boston. He's also an assistant professor of surgery at the Harvard Medical School. His areas of interest include leveraging artificial intelligence and robotics to develop telorobotics applications for cardiac surgery. He's also working on using transfer learning to develop semi-autonomous cardiac surgery that has applications to mitral valve surgery and aortic valve surgery. He's the editor of a forthcoming textbook on AI-driven robotic surgery. It's going to be published by Springer early next year. In addition, Jacques has an interest in global health, biomedical innovation, 3D printing, and the application of robotics in low-resource settings. Joe Zhu is an associate professor of mechanical engineering here at SUNY Poly. Joe earned a PhD in mechanical engineering from the Johns Hopkins University. His main research area is robotics. So within the field of robotics, Joe's research interests include modeling, motion planning, and motion control of robots and multi-robot systems. He's also interested in data analysis, signal processing, and detection and recognition. And he's interested in using techniques of machine learning, optimization, and control for applications of robotics in various sectors, including manufacturing, healthcare, agriculture, and services. Amir Manzoor holds a PhD in bioinformatics from the University of Georgia. He's an assistant professor in the computer science department here at SUNY Poly. In his doctoral research, Amir studied the RNA molecular structure of bacterial riboswitches. He later worked on evolutionary studies about HIV RNA at the National Center for Biotechnology Information, and he researched RNA binding proteins at the National Institute of Arthritis and Musculoskeletal and Skin Diseases as a research fellow at the NIH. He's also worked on long-range RNA interactions in SARS-CoV-2 RNA. His current area of research is sequence design for ribose switches using geometric graph neural networks. So now Nick will lead us off with a presentation on AI in healthcare. Thanks again, Nick, for talking with us.
Thank you, Jim, for that kind introduction. So I'm going to just set up a timer here to make sure I keep with the time. Hi, everyone. It's a pleasure to be here with you. Just a little slight disclaimer. I've done work in information technology policy, most of my work. So the AI is relatively new area for me. But I wanted to, I'm doing some research on AI, and I wanted to make some bold propositions to you today. And I wanted to be a little bit controversial to steer up some conversations that I think we may all find interesting. So I entitled this talk, 3 Predictions, Artificial Intelligence, AI in Healthcare, 3 Predictions for the Future. And I'm going to lay out the 3 predictions that I'm making here. First, AI will not replace healthcare workers, but healthcare workers will need to use AI, artificial intelligence. Policies will lag AI development and will be inadequate. And we can think of them as legal frameworks and as well as internal administrative policies, although I think hospital internal administrative policies will usually be more up to date. Artificial intelligence will have some benefits for healthcare, but it will not improve public health, population, that is the general health of the population. And I wanted to state them strongly and boldly and potentially controversial as such to see what you all think about that. Let's go one by one. So let's establish artificial intelligence. What is artificial intelligence? Here I have a simple definition that I think is concise enough for a conversation, although some people may find it to be limited. So artificial intelligence can be thought of as computerized systems that mimic human intelligence by generating complex responses based on environmental and or human outputs. And I would suggest artificial intelligence is the evolution of computers, which have always been a kind of artificial intelligence. Today, AI uses complex software models, including machine learning models, such as artificial neural networks. So the models that you may be familiar with in ChatGPT, transformer models, those are generally deep learning or artificial neural networks models, but also if-then types of algorithms as used in traditional programs, including, of course, with diverse hardware, mechanical components that need to be used with the artificial technology to either censor the environment or achieve some kind of desired outcome. There are several potential uses of AI in healthcare: virtual assistants and chatbots answering questions, medical questions, both to clinicians and patients, ambient systems and remote monitoring devices that can sense even heartbeats of individuals in a room and then make different kinds of assessments or decisions based on that, diagnostics and medical coding, identifying particular diseases based on several relevant information, therapeutics and drug discovery, suggesting therapies based on different types of information available, simulating impacts of interventions, clinical administration via analysis of admission and treatment patterns and other potential operations of hospitals, DNA and RNA sequencing, and probably other uses as well. So there are a lot of uses of AI in healthcare, and certainly as the first proposition indicated, AI will not replace healthcare workers, but it will be involved in the healthcare field. So healthcare workers serve various roles, but healthcare is a very personal activity. It requires attention to emotions. It requires performance of complex physical activities, and not just in terms of conducting a surgery, but also navigating around a hospital, and also trust. There's a lot of human dimensions of healthcare. 60% of Americans would be uncomfortable with provider reliant on AI in their own healthcare. As a recent survey indicates, I don't think people are ready to start accepting AI to be carrying out most of the activities in healthcare to the extent that it's even able to do so. In a recent study, most respondents reported low trust in their healthcare system to use AI responsibly, 65%, and low trust that their healthcare system would make sure an AI tool would not harm them. There are few roles in healthcare that have been phased out, and many are increasing. So roles that are lost or decreasing are medical transcriptionists, paper record clerks, X-ray film developers, some types of lab technicians, hospital switchboard operations. These are roles, I think, that have been really phased out for a long time, and they're not really roles that are increasing. But there are several increasing roles: nurses, medical doctors, physician assistants, clinical informatics specialists, AI oversight specialists, robotic technologists, clinical data analysts. And as you can see, many of these roles will involve using information technologies, which will include artificial intelligence as well. And I have medical coders here on the left, but even medical coding is not really a role that is decreasing in popularity, and also because of use of AI, and I'll mention a little bit about that. The many roles using technologies assisted by AI, and we have Jacques will speak about that. That's his expertise. Robotic surgery is here to stay. And as I was doing some investigation, it's really developing very rapidly. Some surgeries have seen multifold increase in adoption. I think I read 3 out of 4 prostate cancer surgeries are done using robotic technology. And robotic technology may have AI components that assist in identifying in the precision of the needles and the tools that it has. So there are AI components in these robotic mechanical devices. AI medical coding, AI is being largely established in medical coding, but it's not actually replacing medical coders. They're working together with AI, and medical coding employment is also expected to grow 7% in the next about 10 years from 2021. There are various challenges in AI and clinical coding that actually makes it difficult for AI to completely overtake this kind of activity. Proposition number 2, policies will lag AI development and will be inadequate. Perhaps this is not so much controversial since laws always lag technological development. There are several policy and ethical issues of AI in healthcare: data privacy, data security, data ownership, AI standards, interoperability, equity and access to AI tools, AI use in research and secondary use of data, also legal liability and explainability of if AI makes a decision, who is responsible for that. So various questions of policy here. But as we know from the literature on laws of technology and the social control of technology, technology changes exponentially, whereas social changes are incremental. There's this famous Coleridge dilemma from David Coleridge, where he talks about how it's very difficult to know how to regulate technologies before they are extensively developed because of the lack of information. And then when they are extensively developed, they're also difficult to control their impact. So technologies always lag, laws always lag technological development. There are some frameworks that exist that I think help. So of course, HIPAA has data privacy provisions, but also they lack specifications for technology companies and social media sites. Healthcare also is the #1 field attacked by ransomware. So that's AI technology will probably create new vulnerabilities, and potentially strong policies could require stronger protections. But this is still to be seen. Third and last, AI will have some benefits for healthcare, but it will not improve population health. I think I already mentioned some of this, especially regarding robotic surgery, and I think some of our panelists will talk about this. of the benefits of these new technologies that will probably include some aspect of AI, but it will not improve the general population of the health. We know that health spending is related to decrease in child mortality and various aspects of health. So this, you can clearly see the negative association between child mortality and health spending, and health spending involves the health spending of technologies. This is a graph of countries around the world and their health expenditure versus child mortality. You see clear negative relationship, and also positive relationship between life expectancy and health spending. So as more health spending in a population, and kind of assuming here higher technology spending in healthcare, also increase in life expectancy. Very clear positive relationship. But once again, from the population level, fewer than half in US expect AI in health medicine to improve patient outcomes. 60% feel uncomfortable when the healthcare provider relied, if they only relied on AI for medical care. Also, 38% of the population think that AI would make for better outcomes. About 60% are not sure or don't think AI would make a difference. When hospital administrators are asked where the generative AI in particular will be prioritized and implemented in their health system, usually has to do with operations, structuring and analysis of patient data, workflow optimization, charge capture and reconciliation, so financial activities. Now, there are some activities related to clinical decision-making, treatment and diagnostics, but most of the priorities for AI is related to administrative and financial operations of the hospital. Also, the fastest growing health issues in the United States are obesity, mental health, diabetes, chronic kidney disease, opioid, substance abuse, cardiometabolic disease, and the presence of multiple chronic conditions, which have various social and lifestyle, economic causes. And the new AI technologies are not really addressed, are being developed to address these situations. So these are my 3 predictions. I hope this stirs up some interesting conversation later on. And I thank you for your time.
Excellent. We just have a couple of minutes for a discussion about some of the ethical issues related to AI in healthcare that Nick has already raised. Yeah, so in healthcare, I mean, AI has the potential to improve the diagnosis, treatment, and the outcome for patients, the potential. For example, an AI imaging tool might be used by a radiologist to help read an X-ray. Maybe a generative AI tool might recommend certain treatment options for a patient. Now, in all of these cases, there is a risk that AI could result in an error, could result in a mistaken diagnosis or the wrong treatment option for a patient, in particular if the AI tool is biased, if it wasn't trained on data that's representative of the target population. So just a general question, Nick, in your opinion, like what are some best practices that we can think of to reduce bias in the use of AI in healthcare?
Yeah. So, well, just from my own kind of general understanding, I think there's 2 phases of it, right? So in one phase is on the training, the bias of the training of the AI systems itself. And then the other is in the potential application of actually who receives the treatment. So on the AI training itself, I think firms need to be aware of this and attempt to show how their systems are not being biased or have been trained in several populations in several different kinds of contexts. And of course, hospitals and individuals who will be employing the technologies have a responsibility to ensure the kind of training that the AI systems have had. Now, usually these systems are they are trained, they're tested before being deployed. All right. So I think it's important to be aware of this and just ensure that the systems have been trained across different populations and there is a sort of a verification of that particular aspect in the process. There's a recent California law. I'm doing a study on legislation on AI in healthcare, and because the United States government is not really passing laws to address artificial intelligence at all, and not in healthcare either. And but states are doing so, and there is a provision in California law now that AI systems need to formally check and validate that their systems are not racial and gender biased. So that's something interesting being developed.
Yeah, excellent, excellent. Another, Dan, did you want to jump in?
I can ask later.
Okay. You know, another value in medical ethics.
And also, if others have comments on this,
Oh,
sure, yeah, please.
I do want to mention,
Yeah.
talk about bias. We've had a history of bias in medicine. I mean, it's not an AI issue only.
Right,
For decades, we've had researchers on white males in their 50s, and then they think, oh, that's going to cross over to women or to other minorities. So
Yeah.
the point is we have to be aware of it.
Yes.
And then we also then have to support the idea of making sure that we avoid those kind of biases. So.
Yeah, exactly.
I'm just reading here. I read this morning when you were talking about the states passing AI regulations.
Yeah.
I'm just reading here a typo in the Washington Post. White House drafts order directing Justice Department to sue states that pass AI regulations.
Yeah, and I don't know if you were following this closely, but actually there was a provision in the famous Big Beautiful Bill where they were going to annul, essentially invalidate all of AI legislation passed by states. And I don't know if that's legal in itself, but that actually got shut down. So yeah, there's a strong effort by some involved in government at the federal level to stop legislation on AI. Yeah. Yeah.
It's scary.
Yeah, I mean that's a whole big topic, yes.
They're already using, to my knowledge, AI in things like mammography. So
Yes.
one of the big
Yeah.
things that the doctors are now, I hear a lot of rumbling about, is using AI is going to take over radiology.
Yeah,
Take over is a big word,
right,
but I can see it as using it as a tool.
exactly.
I see some of the benefits. We went to a conference, a psychiatric conference down in New Orleans recently, and people are on the bandwagon about using AI to take their notes.
Oh, yes,
So
please.
which would be a huge benefit for
Yeah.
practitioners, especially when keeping eye contact and looking at your patient and instead of being behind a computer like this. So there's a lot of things in all different realms that are
For sure.
that it could be useful for. But I don't, as a patient, I don't want my doctor using AI totally. You know what I mean?
Well, you are with the other 60% of people. I mean, these surveys, I don't know if they got into this nuance of totally, checked something on AI, but yeah, that's
They dichotomize and
I think I have a follow-up question that might address some of this a little bit.
Yeah.
In terms of increasing trust in AI by patients. So another value in medical ethics that Nick has alluded to is autonomy. Patients want a degree of control over the healthcare they receive. I think doctors also want a degree of control over decisions about the diagnosis of a patient. And doctors want some control over the treatment options that are provided to a patient. So one worry about using AI, a generative tool or an imaging tool, is that AI tools, is that using AI in healthcare, is that the decisions from AI can be made in a black box with no explanation for them. So on the basis of certain symptoms, AI might diagnose a patient with a condition, might recommend a treatment option with no explanation at all for why that diagnosis or treatment option is warranted. And in these cases, it's going to be difficult for doctors and patients to make informed decisions about whether to accept the recommendations of the AI technology, whether to trust them if there's no explanation behind them. So Nick, as you alluded to, in your slides. On your view, how important is the value of explainability in AI? I mean, how important is it that AI tools offer an explanation for their decisions? And is that always possible? Or have the algorithms gotten to be so complicated that it's not always possible to articulate an explanation for a decision in every case?
Yeah, I think it's 67%. I could joke, that's 67% important. I think it's pretty important. And I also don't think that, as far as I understand, it's difficult to impossible to actually know all the steps in those layers of the artificial neural networks to actually help explain how the decision was made. So I think it's important. I think it's part of the reason that people lack trust and why AI will be only employed in certain limited activities. Yeah, so those are the two points. Did you have a comment?
Yes, I did actually, but how is AI going to prevent misdiagnosis if doctors misdiagnose patients every day?
Right, so the idea is that AI somehow will be able to process more information than the doctor. Well, that's just one part of it, right? With AI, an AI tool potentially could analyze a vast amount of information about let's say an individual, the history of the individual, all the blood work of the individual, and all the information about the potential diseases that exist and all the issues that exist, the encyclopedias, right? So hypothetically, the AI would just have so much more information to infer what a particular diagnosis is for a patient, and the same for the treatment as well. Hypothetically.
Hypothetically.
Yeah, go ahead.
Would it take to develop an AI tool of this nature, with the ability to like comprehend or diagnose, considering like you mentioned how there's already cases where there are like AI that can do surgery, like cybernetic surgery. Like how much would it take to develop an AI tool that can like process like the diagnosis and perceive the correct diagnosis to give to a patient?
How much money you mean? How much time?
Yeah, how much money and how much time it take to develop?
Well, I think they are already working on this, and I think the large language models actually they provide medical advice. So if you go into it and type, I have these symptoms, what kind of condition do I have? They will go and process. Oh, you probably have the flu, so on.
Additionally, have there ever been any case with those specific AI tools where they got like a diagnosis wrong?
Yes.
Probably,
Oh,
yes.
yes, sure.
Yeah, I'm sure there are. Yeah. I don't know about research on this, but I'm sure.
Well, the thing is, I've done some serious research on AI concerning students having AI write their papers. So AI, like ChatGPT, it says that it hallucinates,
Yes,
right?
exactly.
It has access to the information that's all over the internet, but the information all over the internet, it's not always the right information. There's a lot of false information, and ChatGPT and all the others have access to the false information.
Yeah, I mean, they probably do a kind of hierarchy of information, especially in the medical context. I don't think they're drawing from YouTube comments. They're probably drawing from.
I know it hallucinates.
No, it doesn't exactly. It hallucinates. It gives wrong information. It makes up stuff. So, but there probably is some research happening on that same question. Like, how often does a particular tool like ChatGPT give you wrong information about a diagnosis? Now, the thing is complicated. There's some simple cases and there's complicated cases, right? So it'd be interesting to see how that differs.
Excellent.
Go ahead.
This is a more general question, but specifically, where are these AI tools and AI that can do like surgeries being involved in? Like, is there like a market for like programmers to like go in there and work on them?
So that's going to be addressed in our next two.
Yeah.
We're gonna have our
Maybe
next two presentations
you would
later.
mention some aspects of that, how AI may be embedded into these, for example, robotic devices that do surgery. So yeah, but it's in all kinds of tools. Like I was saying, the medical coding, assisting coders to identify how the particular diseases correspond to some standard list of disease codes. In radiology, looking at the images to diagnose some kind of issue from the X-ray, and all kinds of administrative activities as well. And so, so there's a lot of activity in that as I understand it. Okay, go ahead.
No, I'm.
But also-
Oh, yeah, sorry.
No, go ahead, please.
But also in more recent months, it's found that AI has been more alive almost. And what if the AI starts to believe it is a patient?
I don't personally, I don't think we're there yet.
Because you're saying that you're going to insert all of this information coming at once from medical text studies.
Well, that's what they're doing. That's what they already have done.
And what if it starts to possess that?
Are you talking, well, I think that you're going into like, what if AI develops some kind of consciousness, and it seems like it does? I think, yeah, I wonder what that would look like. I'm not sure what that would look like. And yeah, I don't know if I would believe it.
It sounds like a sci-fi movie.
Yeah, that's
At this point, it doesn't mean it can't come true.
Yeah.
And
So
there
I-
is-
That's a good question. I don't want to dismiss your question. It's
Yeah.
very interesting.
But there is a view that consciousness requires a certain biological
Right,
matter.
is that.
That's
Right.
gonna be lacking.
Yeah, yeah.
So, great questions. One more question?
I think one of the things you said specifically that it cannot replace healthcare workers, right? So it's not gonna replace us, but it's gonna be a tool that we can use for rapid diagnosis or giving the idea, but it doesn't, you still have to learn and have that decision-making, critical thinking about, so we all know that human bodies are imperfect, right? So your kidney might be a little higher than mine. And we have to be able to know these things. And I'm sure
That's part of
even in
the
these
issue.
big cardiac surgeries, that there are deviations from what's, what would be described as normal. So
Yes.
somehow you have to have the doctors still overseeing
Yeah.
at that level.
Yeah, there's a lot of complex information when we're dealing with bodies
Mhm.
that the AI just does not seem to be able to address.
So there are people that are walking around there with all their organs split. So that does happen, and they're alive and well, so.
No, that's some of the issues that are raised, the differences, and for example, in radiology, that's part of the issue.
Yeah,
Because of the differences in human bodies. It's still not a kind of optimized. The systems are not optimized in the radiology field, for example, in detecting, a malignant tumor, for example, in an X-ray. So that's part of the reason.
Excellent. Well, thanks, Nick.
Madam Chair, did you have a PowerPoint? Nick, would you help?
Let me help you here.
So now Jacques will present on other issues of technology, including robotic surgery in healthcare.
That was a great talk by Nick, and I think it segues nicely into my talk.
not the least.
AI is interesting, but I think we're far away from. Yes.
Okay.
It's coming, it's coming.
Oh, okay.
Oh, but first, let's, 1 second, let me just show you. You can ask online people to ask questions. Let's remember that next time.
You can ask after we.
Yeah,
Yes, that's true.
there'll be an opportunity after we finish, after we finish all the presentations for more questions.
Okay.
Wonderful, thank you.
Yes.
So thanks, thank you, Jim, thanks, Mark, and thanks for inviting me to share some concepts on AI in cardiovascular care. So my background, I'm a surgeon, I'm a cardiac surgeon, but over the last couple of years, I've had increased interest in computer science and in AI. And so for the students and who are here and who are thinking about how you're going to leverage AI, hopefully by the end of this talk, you have some ideas of some of the potential applications of where you want to go with AI. So from the cardiac standpoint, I decided to focus most of my talk on some of the work that I'm doing in valvular heart disease. So generally, there are about 5 million people in the US that have a condition that affects one of their heart valves. And so for the students, the heart has 4 valves, and any of those valves could be leaky, or they could be what we call stenosed from old age. And those patients will present with some of the symptoms that are outlined here. They may have chest pain, palpitations, shortness of breath, lightheadedness, or any of those symptoms. And usually the way they are diagnosed is they go to their primary care physician. He may do an echocardiogram, and then which is an ultrasound of the heart, and they may find out that one of your heart valves might be leaky, for example. As I mentioned, there are 4 heart valves, but for the purpose of this talk, I will concentrate on the mitral valve, which is between your left atrium and your left ventricle. So when it comes to how we're going to apply AI in medicine, so the body has so much of information that we generate, right? From our genomes, our physiological data, which is like our heart rate, our blood pressure. When you go to the doctor, you get an X-ray, you get an EKG, or you get a CAT scan. Most of that data sits in your health records. No one, looks at it. What happened 4 or 5 years ago stays in your records. But all that is a lot of information that tells the story about yourself. And how can we harness the data that you've collected over all these years to tell a story about yourself that is very unique to yourself, but then at the same time can be leveraged to give you a treatment plan based on your story. So when it comes to applications of some of these data sets, what we're doing right now is what we call digital twins, and digital twins are used in the aerospace industry, where you simulate a particular scenario as either when you're building the plane or when you're piloting the plane. And so we're using some of that same technology to develop digital twins of your heart. And so the way it works is we collect all these samples of heart scans, EKGs, we make millions of those, and we build a prototype, right, which we call the digital twin. And then the idea would be that your ultrasound or your echo or your EKG can be compared to that twin that has been built and used to predict what may happen to you currently or down the road. So some of the work that has been done has been around cardiac ultrasounds, where AI is able to look at the echo and then be able to predict if there is any problem with your valve, whether it's leaking, how much is the leaking, do we need to repair the valve, yes or no. So when we apply those same concepts to surgery, in surgery, you're looking at multi-dimensional imaging and videos, right? So you need to look at depth, you need to be able to segment, you need to be able to reconstruct, and you need to take all these different coordinates and data points into consideration. So that makes building an AI model for surgery quite complex, because you're taking all these varied data sets and you're trying to build a story, and then you're trying to train a robot to be able to do the same thing based on all those data sets. So it gets a bit more complex when you look at building surgical the digital twins. But in summary, it's again taking the subject, looking at the different configurations, sensors, taking input of vitals, and then taking different spatial information, and then taking that data and inputting it into a system that recognizes that. So in heart surgery, traditionally, when you go to have a valve replacement, you have a very big incision down your chest. You go on a heart lung machine. We're going to stop your heart and we're going to open your heart, replace your heart, your valve. Then we're going to restart your heart and you're going to have a big, nice incision. And you're going to be in the hospital for 5 to 6 days and then go. That's kind of looks quite morbid, right? Go in and open your chest and all that. So what if we could do the same operation through smaller incisions without opening your heart and without opening your chest, and then use maybe a robot with its little fingers to actually do the sewing? And that's what I'm going to talk to you about. It's the Da Vinci robot, which is the robot that we use in surgery. It's got a console, so you sit at a console here, and then you can see that the robotic arms are placed over the patient. And then when you look inside the console, this is what you will see, right? You will see you'll be looking inside the heart, and then you're going to use these the arms of the robot, which are being controlled here through the console, and then you're manipulating those instruments remotely to do surgery. And the advantage of doing that is, of course, smaller incisions and faster recovery. But one of the things with robotics, it's quite challenging to learn how to use the robot, and you need a lot of cases to learn how to use the robot, and it takes quite a long time for you to master the robot. So in cardiac surgery, I think maybe less than 5% of cases are done with a robot. Most of them are done traditional open surgery. So what if we could train the robot to be able to see and to be able to do some of the steps under human supervision, right? So I think we had the last talk about how there's a bit of mistrust about AI, but to the next point, what we're saying is that AI is great, but it needs to be under the domain of a physician. And so what we're doing in our lab is we're collecting data of patients with, let's say, mitral valve disease. So we're taking their ultrasound, we're taking their CAT scans, and we're taking a video of the operation that we've done. And then we are putting all that into a transformer, and we are training the AI model to recognize the different phases of the operation. And then we are also building large language models to actually tell you what is happening at each phase of the surgery. And the idea would be that you will have that information in your console. As you do the operation, you're getting like a prompt, like a GPS, like when you drive your car and you have a GPS navigation. The idea is to have this as a GPS kind of navigation for you as you're doing your operation. So here is what we've done. So as I mentioned, we've taken videos of patients that we've done mitral valve surgeries. Each video probably has about 40,000 frames. So we take each of those frames, and then we have our scientists, researchers label all these frames of all these videos, multiple videos, and then we built a library called the AutoValve library. So this is an open source. It's not yet finalized, but we hoping in the future will be an open source, library with all the different types of mitral valve videos, with the labels, and then you could build whatever you want to do with those for research. So that's coming down the pipeline. And then the next thing we're doing is we building computer vision tools that such that once you zoom into the heart, it will naturally give you exactly what you are seeing and label them for you. So the chances of you making a mistake is much reduced. So yeah, I'm going to play a video of the first portion where we've built an LLM model just from the videos. So what's happening is that as the operation is happening, the AI is detecting what phase of the surgery you are in, and it's giving you the prompts as to what's happening just by looking at the video. So this is all AI generated. And we have our scientists go over the labels, over the videos to make sure that it is actually correct. So this is how we are training the AI model to actually recognize and label the phases of surgery, as well as the timestamp. We identify the instruments, the action that is happening, and the description of what is going on. And all that is going to be kept in the records. So if, for example, there was a mistake made, you can always go back to minute 4.5. What happened at minute 4.5? You can detect what happened there. That's part of the. So this is what it would look like, right? So you, the computer vision model tells you exactly what is happening, the instruments, the target, and the surgical action. So this is still work in progress. We're collecting many videos to build these kind of models. Now, this is what it looks like with the computer vision anatomical landmark. So basically the AI, and again, this is work, as I mentioned, each frame has been labeled. So it's multiple frames for 40,000 per video. Someone sits there and does all the labeling. So here you can see that we've labeled the heart valve. And this is our computer vision. So basically, once you go in, it tells you what's going on. It's been labeled for you. And then you can see the brush levels here. So you know exactly what each color corresponds to in the heart. And this is how the workflow looks like, right? So it's all these videos, images, labeling, labeled data. Some of it is unlabeled, and we use an AI agent to do the labeling and with the testing set and all that. But this all boils down to this. So this is the anatomical. When you open the mitral valve, this is how this what you will see. And then these are with the labels and the ground truth and the predictions. And right now, as I said, we're still in the process of collecting and adding more data to our database, but it's pretty accurate. It's our 7.8 right now, AUC. Then this is a video of what we believe in the future when you go into a mitral valve, when you sit at a robot, this is what you're going to see, right? So the computer vision will have already done all the mapping up for you. So you know exactly which leaflet is color coded. As you move in the camera, it's going to be changing color to show you exactly what the leaflet or the annulus will look like. So again, this is still work in development, but this is just an early prototype of what that looks like. And so how do we anticipate using some of these tools for robotics? So what we are trying to eventually do is to do a number of things. One is to have a co-pilot, like a GPS system, that will actually help you. So it's not going to take over, but it's going to help you to identify the anatomy, help you figure out what needs to be done, and also prompt you as to what the next steps of the operation should look like. So that's one aspect. The next one is coaching, right? So let's say you haven't done enough of this procedure before and you want to get more proficient with it, you can use this GPS system to help you to improve the task in terms of maybe placing the stitches, the depth of the stitch, and all that. So the next part is coaching. And then the last part would be to integrate it into a robotic system. So the current robotic system don't have what I've described, right? So as you go in, you have to figure things out. And what ends up happening, as I mentioned earlier, only 5% of cases are done robotic or in cardiac surgeries because there's a long learning curve. And the longer you stay on the heart-lung machine, the worse the outcome for you. So how do we shorten that time on the heart-lung machine? Having something like this inside your console will probably help do that. So the idea would be to incorporate that into, let's say, the WG5 and then facilitate the operation for you, either as a novice or even as an expert surgeon. So it's more of an augmentation tool. And the next phase is also training people in robotics, like how do you use this to improve your dexterity on the robot. So in terms of clutching, in terms of suturing, in terms of moving the camera, you can again use some of these tools to help you to improve your efficiency in the robot. What I haven't talked about, which is the next phase of where we're looking at, is now that we've got a video MML that can actually take you through the microball replacement. The next phase is now we're going to train the robot to actually do the operation on its own. So that's the autonomous or semi-autonomous, like self-driving cars. So that's the next phase, and we believe we can get to that phase. It's going to take some time. And again, it's just about collecting the right data, having a domain expert, and then transfer learning to train the robot to actually do the actual operation under the guidance of a physician. So it's not that the robot is going to go, on its own and do it, but it will be under the guidance of a physician. But the robot could place the sutures, could do all the things that I've demonstrated. And that brings us to the last bit of how to democratize surgery. If the robot can do it semi-autonomously, then what it means is that I can be sitting in Boston and operating remotely here in Utica in the operating room, having control of the robot here, and then operating from Boston and helping the surgeon here to do the case. So that's where the democratizing of AI, again, under patient control. And of course, we talked about the ethics, right? So cybersecurity, patient privacy, all those things will have to be figured out. So in summary, this is just a short demonstration of leveraging AI in surgery. But what I would like to leave you with is that to build all these AI tools cannot be done in isolation. It requires partnership between engineers, data scientists, and clinicians. And as I've shown you, we meticulously go through all these videos to make sure that there's no mistake, make sure the labels are done correctly. If there's a mistake, we go back. And so what I'm trying to bring to your attention is that there has to be that synergy between clinicians, engineers, data scientists, ethicists, to build AI that is equitable and that's going to be, could be used by most people. And then you can say, I talk about human in the loop, right? Which again means that we're making sure that we're designing the AI and that it's transparent, accountable, and under full clinician control. So again, there are a lot of AI tools around, and people come and say, hey, I've got an AI that can do the transcription and all that. I say, great. Show me the data of how you built the AI model. And then I find out, well, 99% of it was from some institution where everybody is white male, right? That's not going to work in real world. So I think it's again up to us to make sure that the data that we're using is transparent, is equitable, is representative of all the pathologies that we're looking at. And that's the only way that we're going to be able to build responsible, equitable AI that can be used by everyone. So again, the responsibility is going to be on us to make sure that we do that. And yeah, so this is our group. It's a group of great college students. This is our college. He's a assistant professor. He's a college students in med school. A great group of folks. Then we have also some industry partners that we're working with, who are very much interested in the work that we're doing. But again, this is very early on, and yeah, but it's exciting. So for the students, these are some ideas that you can all think about as you as you go through your programs, and how you need to have a domain expertise very early on, build that domain expertise. And so, yeah, I invite any of you who are interested in collaborating to be part of this. So thanks again for your time, and open to any questions.
Thanks so much. I just want to say done deal. We want to collaborate. So we're going to keep the conversation going. We've got faculty, students across all of our colleges, I think, can contribute here. We also
Yeah.
have a number of new centers, I'm sure our president talking about.
Yes.
That can
Yeah.
collaborate. So this is wonderful. May I just have a question about the current state of the technology when it comes to robotic surgeries? So when it comes to ethics, say two general principles in medical ethics, beneficence and non-maleficence. Do good for others and do no harm. So under these principles, a medical procedure should probably be used only if it's better or more effective than alternative procedures available. So if we look at the history of medical robotics, robotic surgery, I mean, a lot of that history goes back to the military. The military funded a lot of research on medical robotics with the hope that robots would be used to treat soldiers in the battlefield. Now, on the battlefield, there's no other option. I mean, a robot is the only hope, could be the only hope of treating a wounded soldier in the field at war. But in a normal hospital, like Mass General, when there's going to be an alternative to robotic surgery. These surgeries can always be performed manually the old-fashioned way. So just a clarification there, are there any studies or research that have shown that here and now, robotic surgeries result in better outcomes for patients than surgeries performed manually?
Great question. So it's interesting. I just got a grant from Intuitive Surgical to answer that question for mitrals. So right now we know that robotic mitral surgery that's based on the database may reduce the amount of hospital stay, is more expensive, but the outcomes are what they say. We've not shown that there is an improvement in outcomes. But this grant that God is going to kind of go deeper and figuring out whether there is an improvement in outcome. The problem with cardiac surgery, as I mentioned, is only about 5% of cases done robotically. Now, to answer your question with urology, where most prostate surgeries are done robotically now. In fact, if you go to a urologist and he says it's going to cut you open to take out your prostate, you may want to go, to the next friendly hospital because robotic prostatectomy is now kind of the gold standard in terms of reduced length of stay. And I believe there are also improved outcomes compared to open. Because with open, got a big incision, many days in the hospital, one infection and all that. So in prostatectomy, yes, not demonstrated yet in cardiac because just too few numbers. In other surgeries, now most surgeons are moving towards robotics. So I think, the next couple of years, we will see more robotic surgery taking place. And then to answer your question about how robotics started, which was in the military, right? One of the issues at that time with robotics was the network to be able to do telerobotics. Because when this technology was introduced in the 1990s, we didn't have 4G and 5G networks. And so the latency of the network made it such that if you wanted to control a robot remotely, it will take many seconds from the control to the actual action. But now we have 5G networks, so that is pretty much, there's very little latency. And I'm sure in the future, as the networks getting, more powerful, there might be no latency to the point that, as I mentioned, I could be in a different state and still control the robot in another state, just because there's no latency with the with the network. So yeah, I think more work needs to be done to figure out the outcomes in terms of different surgeries, different specialties. But in my mind, I think there's no doubt that as we start to leverage AI in robotics, we will be able to shorten some of the time you spend in surgery, improve communication, improve visualization, improve detection of pathology, and that could ultimately lead to outcomes.
Absolutely. As the technology improves, we can expect better outcomes. There's one other question. Like any activity,
Oops, I'm sorry.
to get good at it, you got to practice it. And the more you practice, the better you're going to get. So robotic surgeries versus surgeries performed manually, they're very different procedures. So to get good at robotic surgeries, as Jacques has mentioned, you have to practice them. But the more that you practice robotic surgeries, the less time will be available to practice surgeries manually. So is there a de-skilling risk when it comes to robotic surgeries? Is there a risk that as doctors perform more robotic surgeries, their skills to perform surgeries manually might decline?
Yeah,
And that might be an issue if cases come up where robotic surgery is not an option. So is there a de-skilling risk of performing robotic surgeries? What's the best way to mitigate that risk?
yeah. So to your point, yes, if you do a lot of one particular operation, you get good at it, and you're not doing the other type of operation, then yes, you may not be as good as you're currently doing. So yes, I think that as you get into more of this minimally invasive robotic, and that becomes your niche, I think you should stick to that niche. If someone is good at doing an open operation and has done it for a very long time, I think it makes sense to say, hey, you know what, I'm not doing these open cases anymore. If you want to open, my partner or my colleague, could be a good option at doing it. And for the robotics learning curve, we have simulators. So, for example, at night I go and sit in the simulator for an hour and I just practice on a simulator, right? Now, in the future, that simulation can happen in your home, virtually using VR, goggles and using all this new technology, and you could practice in the comfort of your home. And again, as robots become more, the technology improves, the network improves, and then you have better AI recognition software, and we get to autonomy, then it's possible in the future, maybe 10 years time, that your operation will be done by the robot under physician control. A good example is LASIK. When you go to have the LASIK procedure to correct your vision, you want the machine to do it, not the human person slicing your trying to cut 0.4 millimeters from your cornea, right? You want the precision
Yes.
machine to do that. So think of it the same way. And I think we'll get to the point where, you want to have your surgery done, you want to go to a place where they have the robotic technology, they have AI, and they have someone who knows how to use the robot, and who's done many of those.
Excellent. Excellent. Other questions?
I want to ask about cost and the ability for especially these rural areas and being able to, afford a Da Vinci. I mean, I know they've been using the technology for a long time. I know in GYN surgery, things like that. But do you anticipate that cost coming down?
Yes. So cost is definitely an issue, and that's why, as I mentioned, the outcomes were about the same, but there's about $5,000 or $10,000 extra cost. But if you go through the economics of the whole procedure, if it's maybe going to cost you 1 or 2 days to leave the hospital early, right? But each day that you're in a hospital is also a couple of thousands of dollars. So the upfront cost might be there, but you might make up for that cost by decreased hospital stay, decreased wound infection, early return to work because you don't have a big incision. So when you have your hysterectomy, the next week you can go back to work because you just have it. Also, when you look at cost, I think you've got to factor all those bits and pieces. But upfront, yes, it's more expensive. Each time you use any of these robotic staplers and all that is an extra cost. But I think what is happening now with intuitive surgery is they instead of, I think they have programs now where you don't have to buy the whole robot, which I think about $1 million. They have like leasing programs where you can lease it and use it. And if you commit to doing a certain number of cases a month, you know, the cost becomes minimal. And then when there's a new robot, you know, you can upgrade to the new one. So I think there are different types of financial plans, but upfront, I think it's a more expensive technology. In the future, when robotic technology becomes much more common, I think the cost will come down. So I think we're just in the early phase of this technology. I know Tesla is trying to build humanoid robots for surgery, and so many other companies are looking at the robotic space. And then one thing we didn't talk about in AI is I think we talked about text, we talked about videos, we talked about images, and I think one of the students talked about consciousness. So the next level is the interaction of AI with the physical world, right? Because right now we're not capturing the physical world, we just capturing data, video, text. So the next layer, and I think there's this Jan LeCun from Meta just left Meta to go and, you know, start his startup on blending that next chapter of AI, which is the physical world. So that would be a very interesting development in the AI space where AI could potentially think and have some judgment. I don't know where all that is going to go, but I think we are going to move into that next phase of AI.
Wow. And nursing will follow critical things. That's the.
Yeah, I mean, it's going to be, but that's why I think if you're building these tools, you need to have the whole team together to build it. You can't just build it in Silicon Valley and bring it, you know, here and say, hey, I built something down in Silicon Valley. You guys want to, you know, use it for a medical scrap, you know? So I think we're going to get to the point where all these things will have to be taken into consideration. Where's the data coming from? How is it built? You know, all these bits and pieces, ethical aspect, equitable aspect, race, sex, all those things will have to be taken into consideration when you build AI models. So I think it's up to us to insist, whether at the leadership level, wherever, that if you're looking into using AI, that it meets all these. You have the checkbox, that it meets all these criteria for you to apply. Otherwise, you're going to get misdiagnosis. And we've seen it where an AI tool will misdiagnose someone from a minority because they've not seen enough of that particular pathology. And they've not seen enough of that skin condition, maybe in a dark skin or in a, you know, Asian skin. So they are misdiagnosed, but it's because the AI tool was not fed multiple different scenarios to learn from.
So we should be thinking now about the ethical and legal principles that should govern the future developments.
Oh.
We gotta be thinking in the future,
Exactly.
the future developments.
Yeah, I think we're just very early in the AI scene. I mean, a lot of this AI tech that's around, many of them are not gonna make it.
Yeah.
But I think it's time to now start thinking holistically how you build these AI tools. And I mean, as you've mentioned, you've got a good, collaborations with the different colleges, different institutions, hospitals, the community. All this needs to be taken into consideration as you move forward.
Other questions? Yeah.
This is a bit of an off-topic question, but as you mentioned before, I'm not sure about how there's the Da Vinci robot was able to like precisely do some incisions to help fix the heart and stuff. Will there be a robot, or if there is a robot that is being developed somewhere that can like make precise measurements for like an amputee to like make them a better prosthetic? Is that in the works, or is that possible?
So, I mean, we have robotic prosthesis, and those are, I think, available, robotic prosthesis. In terms of the measurements, I'm not sure, but again, if you're interested in that space, like the application space, then I think there's a good, hypothesis to generate and say, hey, you know what, I'm interested in building prosthesis for, folks from, people going to war. Then you focus on all the bits and pieces that are required, in that space to get the information to build. So again, it comes down to AI is just, when we say AI, it's a general thing, right? It's like the internet, but we need to focus the AI on particular domains of interest or expertise. And one AI model might not necessarily work. I'm not going to take this and go and apply it to urology and say, hey, you guys want to use this in urology. It's not going to work because the domain expertise was not built around that. So the opportunity for students will be, if you're interested in anything, figure out what that domain expertise that you're interested in following, and just focus on that.
So there's more specialization.
Yeah, and I think, I mean, I never grew up in the era of AI and computer software coding, but if I'm in your shoes today, this is an area that I would love to be in, right? I find it very fascinating as a technology, and I think, for most of you, we keep hearing that AI is going to replace, a huge chunk of the workforce. So, you have to start thinking, what are the areas where domain expertise is needed that you cannot replace? If you're a plumber, that's a skill. You know how to, repair the pipes. You've got your job security, right? So start thinking about how you want to apply whatever you're learning to a domain that's, you only have that expertise. Because I think we hear all these things about AI taking your jobs, and it's kind of frightful, but I don't think it will. I think it will augment in some cases. Domain expertise is going to be needed, but certain things are going to be taken over by robots and AI, like manufacturing. Robot might be able to assemble something much better than you will, but the robot will need to be under your guidance of your expertise. So.
The CEO of NVIDIA said, no one will lose their job to AI, but some will lose their job to others who know AI.
And that's true. So again, domain expertise.
Any questions from anyone on Zoom, Mark?
Nope, not necessarily, so.
Okay.
By the way, we're gonna go a little bit longer, we're gonna go probably about 2:40, or I'm sorry, 3:40, because we do have 2 more presentations, so.
Any other questions? Thanks so much, Jacques. So next, Joe is going to present on other issues about medical robotics and healthcare. Thanks so much, Joe. And Joe is joining us remotely.
Right, and you should have access to share.
Yes, I'm sharing my screen. Can you hear me?
We can hear you.
Okay. Yeah, here we are. Can you see my screen?
Yes.
Okay. All right. Okay, well, first I want to thank Mark for inviting me to give this talk, and I want to also thank Jim for the introduction. I'm a robotics guy in a relatively general sense. I cannot declare myself a specialist in medical robotics. I just give a overview of robotics in healthcare with my personal understanding. All right. Yeah, I thought about, okay, how to do this overview because medical robotics is a very, very big field. And there are a lot of things. Suddenly, it takes one whole semester to cover the topic. So I saw a little bit, I think the best perspective is to talk about the applications. In general, medical robotics is to use a robotic system to enhance patient care. In a sense of how to say, to assist surgeons and medical staff to provide the healthcare. So assistance, this is the keyword I want to emphasize. Again, medical robots are not taking over the job of doctors and supporting staff. And I list out 5 main categories of applications at this moment, including surgery, rehabilitation, hospital logistics, companion, and telepresence. So first, let's look at robotic surgery. Nowadays, surgical robots have been used to carry out, maybe more precisely, to assist to carry out a wide variety of surgery. Some representative surgery include abdominal, cardiothoracic, urological, orthopedic, and also endoscopic. So here I just want to show a few like successful robotic systems doing robot-assisted surgery. This one clearly everybody knows, the Da Vinci robot system developed by Intuitive, and we have a history of development over here. And on the right side we have the current system, as the previous speaker said. So this is the system 5. Yeah, I just have one interesting statistic data over here. It says, okay, I just searched online. It says in 2024, just in 1 year, okay, there were more than 2.5 million surgical procedures were performed in US using Da Vinci robotic systems. So this is a very impressive number, a very impressive number. So this system actually, personally, I feel this is probably the most successful robotic surgery system in the world. I have another slightly different robot, surgical system to show you. This is called the CyberKnife, made by Accurate company. Okay, yeah, this robot, I mean, can do a different type of surgery. The surgery is non-contact instead of using tools. This robot uses a radiation beam. So this robot was specifically designed for neurosurgery and radiation therapy. So use a radiation beam to do the treatment. There's another surgical robot system I want to mention. It is Mako, developed by this other company, which is called the Stryker. And this robot has been widely used to assist orthopedic surgeries, particularly used in joint replacement. There are a lot of other surgical robotic systems under research being developed. I just list out a few representative ones for different aspects over here. Also, generally speaking, these surgical robots provide enhanced procedure and control of surgery, and they make a surgery process minimally invasive, help to reduce blood loss in patients, and help patients to recover faster. Those are the typical benefits of robotic-assisted surgery. The second category of application I want to mention is rehabilitation and therapy. So here I have a couple of images. So these robots are called the end effector robots, and these patients are wearing such end effector robot, and clearly you can see what they are doing. They're basically doing some kind of training for grasping and manipulation. These robots can provide consistent and repetitive exercise and collect data from the patients. Here, I have another, it's a little bit more traditional, right? Exoskeleton. Exoskeleton is considered also one type of robot. This patient is wearing a set of exoskeleton. You can see he's under the help of supporting staff over here. So basically, such as exoskeleton robot support this patient to do gait training and help to improve motor function. Here I have another enhanced system. This is a robotic treadmill gait trainer. So clearly, such a system provide a robotic gait training. And all these rehabilitation robot system, they provide increased intensity and consistency of the training process. And they also help to collect patient data during the training process objectively. Moreover, they help to reduce the pain in patients and to facilitate patient engagement during the training process. This is a third main category of current application, logistics and hospital service. Again, I want to show you a few robot systems for this purpose. Here we can see we have these mobile robots. These mobile robots, suddenly they can carry load, so they can deliver stuff automatically inside the hospital environment. Some of them also have, they have face. They can interact with patients and staff and doctors. All right. Now, here we have another couple of mobile robots. Each of these mobile robots carry one disinfection light source. These are disinfection robots. They basically use a disinfection light to disinfect a operation room or other hospital environments. So the robot on the left side carries a xenon light source. On the right side carries a UV light source. Okay, more robots. These robots are working in pharmacy. So you can see their basic job is to pick up medicine from the shelf, and distribute them. Generally speaking, these logistic and service robots, they can improve the efficiency of service, improve the safety and accuracy of service. Also, they help to reduce the workload of hospital staff, and they make the hospital service faster, more reliable, and cost effective. All right. Yeah, another category of application is a companion or companionship. And I want to show you again a couple of robots here. The robot on the left side, it can move around. It's a mobile robot, and it has a human look, and it also carries a screen. It can interact with a patient, with a hospital staff. All right. So such a robot basically can provide emotional and social support to patient, and facilitate communication, and also assist with care activities and daily activities. Now, on the right side, we have another robot. This robot is a lot simpler. It basically sits on the tabletop. It cannot move around. However, it can still interact with patients to provide emotional support. And the main purpose of this robot, tabletop robot, is to provide health monitoring and also to remind patient to take medicine on time. All right, more robots here. These robots are humanoid robots, and they are very interactive and very friendly. They are widely used in the treatment of children autism. So they basically those children with autism play with these robots, and this will help them to get the treatment and recover. So basically, these companion robots they provide support to patients to reduce loneliness and social isolation. They provide emotional and mental health support. They encourage social interaction. They also provide medication reminder, health monitoring. All those are very beneficial functions for patients. They also provide support to healthcare providers to reduce caregivers' workload. They, as a result, they help to increase the efficiency of the service. All right. Okay, another category of application that is telepresence. Telepresence. Again, a few robots here. So you can see these are all mobile robots, and these robots all carry a screen. Then on the screen, you can see doctor's face showing up. So basically, the main purpose of these robots is to provide telepresence in order to help those doctors to provide remote consultations and help to connect the patients with doctors, help to connect patients with their families. The robot on the right side also has a robot arm. You can see this robot arm is picking up something. This robot has more extended functionality, which can help hospital logistics. These telepresence robots, they provide a lot of help. Basically, they can bridge the geometrical gaps between patients and doctors, between patients and family. And they help to improve the efficiency of medical service. Something very important is to reduce the exposure of medical staff to infectious disease. And also, they can provide companionship to patients. So that was quick. Those were the current mainstream applications of medical robotics. What about the future? Medical robotics is a continuously evolving and developing field. We envision that the future of the medical robotics will become even less invasive and will be more AI powered and can provide more personalized and more precise either surgery or other medical service. Then we envision that the direction of advancement for the next stage of medical robotics will be mainly in these directions, including surgery, diagnosis, rehabilitation and patient care, lab automation, and workforce support. And the driving force, driving technologies behind the advancement of medical robotics will include data analytics because more and more application will be data driven, and artificial intelligence, including machine learning, and also including more advanced robotics technology, such as smaller, softer, and more adaptive robotics. I will just stop over here. Okay. I hope I kind of made my presentation under 10 minutes. All right. So by saying that, I'm a robotics guy, but I cannot declare myself as an expert in medical robotics. I did some work on medical robotics, but it was kind of limited. But I'm open to potential collaboration with expertise in healthcare. And hopefully in the future, we have a great opportunity to work together. Well, again, thank you very much for listening to my talk.
Excellent. Thanks, Joe.
All right, so I'm going to stop share.
Sure. So Joe, you're part of the team here. We're all going to be collaborating together on these issues.
That will be great. I'm looking forward to that. We got to talk more.
Absolutely. So Joe, there are different kinds of robots that can be used in healthcare.
Yes, yes.
As Jacques talked about, there are robots that can be used to assist in surgeries. As Joe mentions, there are also robots that can be used just to provide care and therapy to patients. So care robots might be used to feed a patient, clean, bathe a patient. Now, a care robot might be a real benefit to some patients. For example, some patients might have a desire for privacy when they're eating or bathing. Maybe they don't want to be observed by other people when they're eating or cleaning themselves. And care robots can provide a patient with that option to receive care without being observed, give them more privacy. That's great. But I wonder if there's also a downside risk here of these care robots. Might they depersonalize or dehumanize healthcare in ways that are harmful to patients? Patients in a hospital or a nursing home, they can be scared, lonely. They might need to be touched. They might need an empathetic person to talk to. And healthcare workers often provide that comfort, those meaningful personal interactions with patients that improves their quality of life. Is there a risk that care robots or therapeutic robots could result in a less personal, a less humane form of healthcare that ultimately leaves patients worse off, more lonely?
I think that as the robotics technology further advance, so nowadays, like for example, soft robotics make the robotic gripping softer. So and also people are doing research for all kinds of materials and to make the robotic touch not so rigid. All right, so. So so on one side, the technology is improving. No question about that. The robots will become better and better. Not from all the aspects, let's say from hardware, from material, and also from intelligence. All those improvements combined together will make the robot more friendly and better to address all kinds of concerns. So basically, that is a driving force to move the technology forward. So I'm just an engineer and doing robotics development, design and control. So if there is any like a feedback from the practice side, let's say from hospital side, from healthcare provider side, say as long as they have this concern, they say, okay, we got to address this problem. Then as an engineer, I need to bend my head to find a solution to address it. So that is actually a driving force, a driving motivation behind the technology development. And people have been doing this and that. And actually, the previous speakers, they also mentioned something on that line. So for example, Dr. Jackies, his group is developing this this technology, imaging-based technology, to help to make the surgical robot more autonomous and more safely autonomous, or autonomously safe, or something like that. I think that is a effort in that direction. That is one effort in that direction, and also we certainly during the practice, at least at this moment, when the technology has not been developed to that safe level yet, a human in the loop or doctor in the loop is always the keyword. So we cannot eliminate the doctor. We cannot eliminate supporting staff. And in some of those images I show in my slide, you can always see let's say hospital staff always work together side by side with the robot. So in that way, that will at least at this moment address the concern you just mentioned. Dehumanization basically at this moment. The patient will be taken care not only by the robot but also the hospital staff. In fact, the robot is just play the role of a assistant for the hospital staff. At this moment, mainly is to, let's say, to reduce the burden on the hospital staff, not to completely replace the hospital staff. Even for like a robotic surgery, more precisely, I prefer to call that robot assisted surgery at this moment. So the robot is the assistance. Yeah, for example, a surgeon who do operation using Da Vinci robot system. Okay, the surgeon is the actual controller. So Da Vinci robot system at this moment, it's still mostly a remote controlled robotic system. So the surgeon basically sit at the console, look at the image, then do the remote control using joystick, right? So that means something. In the future, as the previous speaker said, okay, probably the next level of surgical robot will become more autonomous, partially autonomous or fully autonomous. I will say more realistically, partial autonomous maybe sounds safer, right? Yeah, because my understanding is a partial autonomy is to address some kind of local and how to say hard to reach positions and places. In that way, to provide the how to say again to provide assistance to the actual surgery operator actual surgeons and medical staff. So again, my let's say my view at this moment is a robot is assistant. Robot is assistant for all those current application.
Excellent. That's great. So like robots can complement the work of healthcare workers, not replace them. Perhaps they could be used to free up the time of healthcare workers so they could have more meaningful personal interactions with patients. Excellent. Are other questions for Joe? Other questions for Joe on medical robotics, other types of medical robotics? All right, thanks so much, Joe, for talking with us.
Well, thank you very much. No problem. If there's any further question later on, yeah, I'm open. All right.
Yeah, feel free to reach out to Joe anytime. All right, so now Amir will present on bioinformatics.
Thank you so much. I think my background is not very good. Can everybody see my slides?
Yes.
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 Okay. All right, great. Well, thank you so much for this great opportunity, Mark and everyone else. Great talks. I'll put my timer for around 10 minutes, and I apologize for the background noise. So I'll be talking about general information about what bioinformatics is. And in the second half of the talk, I'll go into some specialized area in bioinformatics, which is kind of my own expertise. A little bit about myself. So I actually was an electrical engineer and most of my undergraduate and graduate studies. And at some point, I was very interested in how things are done across the field in nature, or how, you know, some of the things we learn in engineering is actually manifested in the world around us. And that's what took me to bioinformatics. So I'm going to give a little bit of introduction about that. And for those of us who just want to kind of have an explanation of what bioinformatics is, anything that deals with developing a computational tool for analyzing biological, medical, behavioral, or health data is referred to bioinformatics in general. So it's a very broad field, and just not just peculiar to us humans. as we are gathering more and more kind of genetic information across the board, across the kingdom of life, there's there's more need into better storing of genetic information and more algorithms to help us learn from how evolution is done or how diseases are happening. So this is when you say bioinformatics, it deals with any kind of living organisms out there. And because there are some things that are ubiquitous to all that. We all have, as you know, mammalian cells, we all have DNAs that produce our proteins. So some basics about biology, which I know most of us are aware of. So most of the genetic information basically stored in our DNA, and throughout our life cycle, they get kind of translated into RNA and proteins. So we're talking about great amount of information, billions of cells for every humans, and there's so much kind of information and interaction that's happening. So just understanding that kind of data and storing that would be a great challenge. So this is just an example of how genetic data looks like. So we have strings of genetic information that are, if you zoom in, they are just bits of information. And storing them, comparing them across the board, that would be the job of a bioinformatician. And of course, these are just more information about how genetic information is transcribed and translated into proteins, which basically requires more analysis. And there's another layer, even in the, when we go to the cell layer, the cell itself is like a kind of the basic unit of life. It's a place where you have tens of thousands of genes and proteins and RNA and other small molecules that interact with each other to fulfill a biological pathway or a phenomena. And studying that interactome itself requires a lot of system level analyses, which is another layer of bioinformatics. So there's a lot of things that people are interested in bioinformatics. Some people want to study evolution, some want to study diseases and zoom into what mutations in our genes can be related to some genetic disease that we are susceptible to. So that's also bioinformatics that has given rise into a lot of projects out there in the past decades that we focus on collecting information. I'm sorry, I'm going a little bit fast on this. Just want to make sure that we get into the main part. So there are a lot of slices and applications depending on what aspects of genetic data we are looking at. Sequence level, is it cell level? Is it across organisms? Is it within the organism? And this information is exponentially growing. And so now I'm going to switch gears in second part of it and just focus on just one aspect that I was interested in most of my career, past decade or so, and which was structural biology. So I specifically work on RNA structure, which is, I'm just going to skip the sequence part. Before I get into that, just another small introduction about what bioinformatics is. So essentially, we're talking about an interdisciplinary field. That's an intersection between engineering, as was spoken by other people, computer science, and molecular biology. And basically, the challenge is that we have biological data coming in. So what we have to do as bioinformaticians, computer scientists in these fields, develop tools that can analyze those data and help the scientists out there. So the kind of the workflow in bioinformatics would be, there's a biological problem. We have to do a mathematical modeling of the problem statement, develop a solution, an optimal solution or an algorithm, and of course, then produce it and then apply it into biological phenomena. So having said that, now I'm going to switch into my field, RNA molecular structure, very interesting area. So as you know, RNA molecule, again, ubiquitous across a kingdom of life, exists in humans, viruses everywhere. You probably have heard of viral RNAs and RNA therapeutics everywhere. And it's an interesting molecule its function is related to its shape. So the structure of the molecule actually dictates what it does. And when you kind of zoom into the structure of the molecule, it kind of abides by a certain fixed rules of how it zips around itself and forms a structure. So there are some, modeling this RNA structure requires kind of a mathematical probabilistic approach where you can kind of, people use covariance models to kind of imitate the structure of an RNA. This is very interesting for people who are developing therapeutics where want to design a sequence that will conform into a specific structure to fulfill a task. So that's the mathematical aspect of it in the bioinformatics. And there are thermodynamic models out there that imitate prediction of these structures. And of course, so you have cellular RNAs, the RNAs in our body, you have viral RNAs, HIV is an RNA, coronavirus was an RNA, and you have ribose switches. These are amazing RNA switches in bacteria that can shape their form. It's a very interesting field. And this molecule is so versatile and such a high plasticity that it has, that exists across the board. So just going into the kind of the point of RNA. So one of the studies I did was I was looking at HIV, where we would look at the, the structure of the RNA in HIV and see how it's evolving over time. So we did some evolutionary study on the HIV, and we found that some region called nephRNA is kind of evolving faster than other regions. So these evolutionary study help medicine and help kind of come up with better resistant drugs. I would say we haven't completely cured this dealing with HIV, but at least we kind of slow it down. So understanding how HIV evolves, that kind of, and studying it from different aspects and the genetic information of it, that could be rewarding. Of course, coronavirus is another very long viral RNA, 3 times more than HIV. In terms of its length, and I took some time studying its long-range interactions. It has a very beautiful, I would say, very kind of a complex, beautiful way in a way that kind of forms knots around itself and performs versatile functions. Understanding that could be rewarding, and developing certain drugs or antibodies that can help us deal with. Again, slowing down its evolution and spread, of course. And finally, I'd like to end by specifically what I'm working on, which is ribose switches. So ribose switches are those RNAs that can switch their structure. They're mostly found in bacteria. So this is a TPP ribose switch, that it develops a vitamin, and it has 2 structures. And this is very much of interest for people who develop drugs. They want to develop RNA devices that can switch between 2 structures that is triggered by a specific ligand. Here, for example, thiamine pyrophosphate triggers that switch of an RNA. So I personally work on designing these RNA structures. And of course, we have, they exist in nature in the bacteria, but we want to design more structures. And that's where the deep learning or the AI comes in. This is yet a very different aspect of using AI, which, the great, speakers spoke about different angles of AI in robotics and everything. But here we're kind of using deep learning to learn the geometric patterns of the RNA molecule and see if we can imitate that structure to develop our own devices, RNA devices that can target specific elements in the body, basically designing drugs. For that, we need to have atomic resolution data, of course, thanks to the cryo-EM and other NMR, other instrumentations that now they're collecting a lot of data. So taking that atomic resolution structure and using geometric deep learning, which deals with basically learning geometric structure across the board, we can kind of focus on developing a platform, an AI platform that can actually design our specific desired RNA structure or molecular structure, basically by molecular design. So this just goes over some of the mathematics and also the computational side of things, where basically learning about the atom locations and feeding that into the machine, into deep learning machine, help us learn about those geometries and develop our own devices. So graph neural networks, that would be the keyword here, are one of the state-of-the-art models that are being used in that regard. And this is the field that I'm working on. Currently, we are developing, we are working on a specific RNA FMN riboswitch with Albany, and we're trying to to see if whatever we design also has the same expected functionality if we test it in a lab under in vitro studies, for example, to prove its mechanism. So just wrapping this up, bioinformatics is very critical to human health, and it encompasses all organisms, but especially in therapeutics and evolutionary studies, bioinformatics can really help. And it kind of relies on combining knowledge from different fields, and it is collaborative, as my other colleagues spoke here. It's not something that one field can do. Inherently, it has interdisciplinary dimensions. And thank you so much for your attention. We are offering a course also in the spring on bioinformatics and computer science departments. And I'll just stop here. Again, I apologize for the background noise, and I'll just stop sharing.
You're coming in loud and clear, Amir. Thanks so much.
Oh, that's great to hear, because I was very worried. I hear so much noise here. Well, that's good to know. Thank you.
Loud and clear. Any questions for Amir on bioinformatics?
Tell us about that class you're teaching in the spring.
Okay, it's 490, and I think, yeah, we have a cross section with the graduate level as well. It's an undergraduate 490, and then graduate 513. We focus on the basic of bioinformatics for those who come from either computational or the biological side. We cover both bases there, but then at the second part of it, we'll dive into the application of deep learning, and I haven't touched on a lot of things here. Application of general, even LLM models like transformers into biology, if that answers it.
Are there prerequisites for it?
For the computer science people, there's a 240 prerequisite, which is the algorithm. For the non-computer science people, no, we just let people in. Me and the chair, we will we agreed that we would have people from biology, physics, chemistry, whoever is interested, and also the graduates from the data science, they can come in. But for computer science people, we put the algorithm prerequisites. Yeah.
So Amir, one question, it's kind of abstract, right?
Yeah.
Bioinformatics, it involves the collection of personal data and the digitalization of that data. And as you mentioned, some of this data can be very sensitive.
Yeah.
Reveal whether someone has HIV or COVID. So people can have an interest in keeping that personal data private. Is the bioinformatics. And I guess one way to protect the privacy interests of people is to de-identify their data, remove their names and other unique identifiers from their data. But given all the data that's available now, right, there might be a risk of re-identifying data that has been anonymized. So it's kind of abstract, but on your view, are there ways to de-identify data that mitigates the risk of re-identifying it to an acceptable degree while keeping the data useful?
It's so interesting that you actually bring this question up. I think this is the most important question, and it shows the double-edged sword of this bioinformatics. I agree with you. There is a serious problem with probing into identifying patient data, because we rely on that. And there are many approaches people already are taking to de-identify data. Absolutely. To protect the identity of people who participate in these studies. I would like to just add one small comment about this. This problem is so pervasive and so difficult to handle that it just is not even limited to the genetic data of patients. I'll give you an example. A study we were doing in NIH dealt with, analyzing the HIV strains, the viral strains within the body of these patients who had AIDS. And interestingly, the HIV is so adaptive that it becomes such a specific strain peculiar to every person that if you, for example, if I was infected with HIV and if you knew the strain that I was infected in, you would identify me. So to answer your question, even the scope of it is kind of very wide. It's not just my genetic or your genetic data. Is anything that you are infected by could identify you in a way. And so that's one problem. Also, there are measures that are taken not just to protect privacy, and that's not peculiar just to genetic data for anything, but also the way you apply that to machine learning. So as we know, if you look at machine learning from another aspect, it's not just a prediction box, it's a compression box. It compresses your genetic data. And although it doesn't explicitly look that way, it could be used to retrieve the genetic information. So there are now novel methods to restrain the training of these models so they do not record the training data or the genetic information that's given to them. So there are algorithms in this field, there are conferences, there are talks about it. But this is such an important question, and I think people should do more to address it. Thank you.
Thanks, Amir. So thanks, Amir, and thank you again, Nick, Jacques, Joe, and Amir for talking with us today. This is
Thanks, Jerry.
If anyone has any other questions, I think we could stick around
Stick
for a couple
around,
more
right?
minutes.
And we appreciate going over like this. There'll be an extra something in your paycheck. I don't know what.
Well, extra cookies in the back.
Yeah,
Please
extra
take them
cookies.
with you. They're all yours.
I'm gonna remember you said that.
Thanks, everybody online. Feel free to email us any questions if you want to chat about this.
Thank you very much.
Thank you. Thank you, guys. Thank you for hosting. Thank you.